Okay, and so I would like to introduce Oana Vasiliu, who is the STD Epidemiology and Surveillance Manager for the Virginia Department of Health. And she's going to start with giving you an overview of the syphilis epidemiology in the US and in Virginia.
Thank you very much, Barbara. Can you hear me?
Yes.
Great. So hi, everyone. Thank you for joining us and for attending this training today. I'm very excited to be here. I'm the director of the STD Prevention and Surveillance program in the Division of Disease Prevention at the Virginia Department of Health. And I am here today to give you an overview of syphilis epidemiology as it stands nationally and in Virginia. So I listed here the learning objectives for this portion of the training. Hopefully, by the end of this presentation, the goal is to understand the epidemiology of syphilis in the United States and in Virginia. This includes the recent case trends, also who the most affected populations are with syphilis, where in the United States and Virginia are the geographic areas of high syphilis incidence, as well as become aware of the latest trends in syphilis rates and also health disparities related to syphilis acquisition. Also, the part of the learning objectives include the understanding of the role of the public health in interrupting disease transmission, including disease surveillance, contact tracing, and partner services. So 4 key facts about syphilis. Syphilis is a genital ulcerative disease caused by the bacterium Treponema pallidum. This sexually transmitted infection is associated with significant complications if left untreated, such as organ and nervous system damage, and can facilitate the transmission and acquisition of HIV infection. Additionally, historical data demonstrate that untreated syphilis in pregnant women, if acquired during the 4 years before delivery, can lead to infection of the fetus in up to 80% of the cases, and may also result in stillbirth or infant death in up to 40% of the cases. These are some of the reasons why syphilis prevention and adequate treatment of those infected are considered a major public health priority. I will start with an overview of syphilis epidemiology and basically data in the United States. And all the data in the national section of this presentation have been obtained from the CDC 2018 STD Surveillance Report, which I referenced at the bottom of the slide. The 2019 data has been delayed this year, but it's expected to be released very soon, hopefully within the next couple of months on the CDC website. Hopefully we'll have updated 2019 data to look at the trends, at the more recent trends nationally. For the purpose of case surveillance, syphilis is classified into 4 consecutive stages of infection, into primary, secondary, early non-primary, non-secondary, and late or unknown duration syphilis. Primary syphilis is the first stage of infection with Treponema pallidum, with 1 or more ulcerative lesions, usually appearing within 3 weeks of infection. The secondary stage of syphilis has a wider array of symptoms, usually a rash, and other signs such as mucus patches, condyloma lata, and alopecia. The early non-primary, non-secondary stage has no symptoms and lasts until within 12 months of the date of infection. Syphilis of late or unknown duration is a stage of infection in which the initial infection has occurred more than 12 months previously, or in which there is insufficient evidence to conclude the infection was acquired during the previous 12 months. I will not go into the more of the clinical details of staging for the diagnosis purposes, but did want to mention that the primary and secondary stages are symptomatic and infectious. So this line graph presented here shows the United States rates of reported total syphilis, primary and secondary syphilis, and early non-primary, non-secondary syphilis, dating back to 1941, when syphilis reporting began in the United States. Current increases in syphilis can be seen in the context of historically high syphilis rates from the 1940s. In 2018, 1,115,045 total cases of syphilis, representing all the stages of disease, were reported in the United States. And this is the highest number of total syphilis cases recorded since 1991. The 2018 case count for total syphilis reflects a 13.3% increase from 2017, when there were 101,584 cases. Reports of primary and secondary syphilis and early non-primary, non-secondary syphilis cases or incident stages of infections increased as well during 2017-2018 nationally. This line graph shows rates of reported primary and secondary syphilis cases by United States region from 2009 to 2018. In 2018, the West had the highest rate of reported primary and secondary syphilis, with 15 cases per 100,000 population, followed by the South with 11.1 cases per 100,000 population, the Northeast with 8.7 cases per 100,000, and the Midwest with 7.1 cases per 100,000. During 2017-2018, the primary and secondary syphilis rate increased 16.4% in the Midwest, 15.6% in the South, 15.4% in the West, and 10.1% in the Northeast. This is a map that displays 2018 rates of reported primary and secondary syphilis cases by state and territory in the United States. In 2018, rates of reported primary and secondary syphilis cases per 100,000 population ranged by state from a low of 1.8 in Vermont to 22.7 in Nevada. The rate of reported primary and secondary syphilis cases in the District of Columbia was 40.2 cases per 100,000 population. During 2017 to 2018, primary and secondary syphilis rates increased in 74%, or in 37 out of the 50 states in the District of Columbia, and remained stable or decreased in only 26%, or 13 out of 50 states. Virginia in 2018 was at an 8.3 rate per 100,000 for the diagnosed cases. Going deeper at the county level, this map shows 2018 rates of reported primary and secondary syphilis cases by county. The morbidity rates displayed here at the county level ranged from 0 to 304 cases per 100,000 population. In 2018, 61.5% of reported primary and secondary syphilis cases occurred in just 70 counties or independent cities. Of 3,142 counties in the United States, 556, or 17.7% of all the counties, had a primary and secondary syphilis rate of 8.8 cases per 100,000 population or greater. 557 counties, or 17.7%, reported a rate from 4.2 to 8.7 cases per 100,000 population. 531, or 17% of the counties, reported a rate from more than 0 to 4.1 cases per 100,000 population. And 1,498 counties, or 47.7% of counties, almost half the counties in the United States, reported no cases at all of primary and secondary syphilis in 2018. As it has been observed in previous years, in 2018, the rate of reported primary and secondary syphilis cases among men at 18.7 cases per 100,000 males was much higher than the rate among women at 3.0 cases per 100,000 women. And men also accounted for a large majority, almost 86%, of primary and secondary syphilis cases. Among men, the rate of primary and secondary syphilis has increased every year since the year 2000, and during 2017 to 2018, the rate among men increased 11.3%. In contrast, the primary and secondary syphilis rate among women fluctuated between 0.8 and 1.7 cases per 100,000 women during 2000 to 2013, but has increased substantially since 2013. During the time period from 2014 to 2018, the primary and secondary syphilis rate among women more than doubled at 172.7% increase. During 2017 to 2018, the primary and secondary syphilis rate among women increased 30.4%. These increases in male and female primary and secondary syphilis rates were observed in every region of the country during 2017 to 2018. Men who have sex with men continue to account for the majority of the primary and secondary syphilis cases in 2018. Of 35,063 reported primary and secondary syphilis cases in 2018, 53.5% or 18,760 were among men who have sex with men, including 16,905 or 48.2% of cases among men who had sex with men only, and 1,855 or 5.3% of cases among men who had sex with both men and women. Overall, 5,416 or 15.4% of cases were among men who have sex with women only. 4,995 cases were among women. 5,858 were among men without information about sex of sex partners, and 34 cases were reported with unknown sex. Among the 24,176 male cases with information on sex of sex partners, a large majority of them, 77.6%, occurred among men who have sex with men. This bar graph shows rates of reported primary and secondary syphilis cases by age group and sex in the United States in 2018. The highest rates were observed among men aged 25 to 29 years, with 55.7 cases per 100,000 males, men aged 30 to 34 with 45.8 cases per 100,000 males, and men aged 20 to 24 years with 44.6 cases per 100,000 males. The higher rates among females were among those aged 20 to 24 with 10 cases per 100,000, and those aged 25 to 29 with 9.4 cases per 100,000. So rates among men are much higher than rates among women. As in previous years, in 2018, rates of reported primary and secondary syphilis cases were highest among persons aged 25 to 29. In 2018, the highest rates were observed among men aged 25 to 29, or 55.7% cases, 30 to 34 at 45.8 cases, and 20 to 24, 44.6 cases. The highest rates among women were among those aged 20 to 24, and those aged 25 to 29 at 9.4. During 2017 to 2018, the overall rate of reported primary and secondary syphilis cases increased in all age groups among those aged 15 years or older. The rates increased from 14.9% among 15 to 19 years old, 10.3% among those aged 20 to 24, 12.6% among those aged 25 to 29, 21.2% among those aged 30 to 34, 17.2% among 35 to 39, 7.2% among aged 45 to 54, 21.1% among those aged 55 to 64, and 28.6% among those aged 65 or older. In 2018, persons aged 15 to 44 accounted for 80.6% of reported primary and secondary syphilis with known age. Looking at this data by race, in 2018, the rate of reported primary and secondary syphilis cases was highest among Blacks at 28.1 cases per 100,000. And also the primary and secondary syphilis rate among Blacks was 4.7 times the rate among whites at 6.0 cases per 100,000. The rate among Native Hawaiians or other Pacific Islanders at 16.3 cases per 100,000 was also 2.7 times the rate among whites. The rate among American Indian Alaskan Natives at 15.5 cases per 100,000 was 2.6 times the rate among whites. The rate among Hispanics at 13 cases per 100,000 was 2.2 times the rate among whites, and the rate among Asians at 4.6 cases per 100,000 was 0.8 times, so lower than the rate among whites. During 2014 to 2018, the primary and secondary syphilis rate increased among all race and Hispanic ethnicity groups. The greatest increase during 2017 to 2018 was observed among American Indian Alaskan Natives, 40.9%, and also those who identified as multi-race increased 22.1%, followed by Native Hawaiian or other Pacific Islanders at 19% increase, whites at 11.1%, Blacks at 17.1%, Hispanics at 13%, and Asians 9.5%. So across the board, rates increased during this time period for all race groups. This pie graph shows the distribution of primary and secondary syphilis cases by sex and sex of sex partners in the United States just for the year of 2018 reported cases. Men accounted for 85.7% of reported primary and secondary syphilis cases. Of 35,063 reported primary and secondary syphilis cases in 2018, 18,760, or 53.5%, were among men who have sex with men, including 16,905, or 48.2% of cases among men who have sex with men only, and 1,855, or 5.3% cases among men who have sex with both men and women. Overall, 5,416, or 15.4% of cases, were among men who have sex with women only. 4,995, or 14.2%, were among women. 5,858, or 17%, were among men without information about sex of sex partners, and 34 were reported with unknown sex. Reported cases of primary and secondary syphilis continue to be characterized by a high rate of HIV co-infection, particularly among men who have sex with men. In the United States, among primary and secondary syphilis cases reported in 2018 who have a known HIV status, 41.6% of cases among men who have sex with men were HIV positive, compared with only 7.9% of cases among men who have sex with women, and 4% of cases among women. This line graph shows reported cases of primary and secondary syphilis by reporting source and sex in the United States during 2009 to 2018. As you can see, the proportion of primary and secondary syphilis cases that were reported by STD clinics has declined by nearly half over the last decade, from 31.1% of cases in 2008 to only 16.3% of cases in 2018, while the number of cases reported from non-STD clinic settings has increased. In 2018, private physicians and health maintenance organizations and STD clinics were the most common reporting sources for all reported primary and secondary syphilis cases nationwide, regardless of the sex of sex partners. Let's talk a little bit about congenital syphilis at the national level. Congenital syphilis is a condition caused by the transmission in utero of Treponema pallidum from an infected mother to her fetus. These cases come in a wide spectrum of severity, from inapparent infection at birth to severe cases that are clinically apparent. Some infections result in stillbirth and infant deaths. In 2018, there were a total of 1,306 reported cases of congenital syphilis, including 78 syphilitic stillbirths and 16 infant deaths, and a national rate of 33.1 cases per 100,000 live births. This rate represents a 39.7% increase relative to 2017, when the US registered 23.7 cases per 100,000 live births, and a 185.3% increase relative to 2014, when the US recorded 11.6 cases per 100,000 live births. As has been observed historically, This increase in the congenital syphilis rate has paralleled increases in primary and secondary syphilis among all women and reproductive age women during 2014 to 2018 at 172.7% and 165.4% increases, respectively. The national rate of reported primary and secondary syphilis cases reached a historic low in 2000 and 2001, which at the time sparked hopes for the possibility of syphilis elimination. Unfortunately, those hopes were short-lived, as the rates have increased almost every single year since. This increase was largely attributable to an increase among men, and in particular among men who have sex with men. In the last 5 years, the primary and secondary syphilis rate among women also almost tripled. Rates have increased among both men and women. Also, as a result, rates of reported congenital syphilis cases also increased substantially during 2014 to 2018. Men who have sex with men continue to account for the majority of reported primary and secondary syphilis cases in 2018. The highest rates of primary and secondary syphilis in 2018 were observed among young men aged 20 to 34 years, especially in the western region of the US and among Black men. So that's pretty much the national summary for the 2018 data. I expect that we might see 2019 data that looks somewhat similar. The challenges for reporting 2019 data have delayed the national summary for 2019. So like I said before, expect an update within the next couple of months from CDC. So switching back to syphilis in Virginia, let's now go over the epidemiology of the infection in our state. All of the data in the Virginia section of this presentation came from Virginia's STD surveillance data system, which is used to collect information in the form of positive lab reports and case reports on all reportable STIs. And I should say that this data is updated as of October 1st, 2020. And the final numbers for 2019 have been posted on our website. In the past 20 years, primary and secondary syphilis rates increased substantially in Virginia. Case rates went from up from an all-time low of 1 case per 100,000 population in 2003 to 7.5 cases per 100,000 population in 2019, which represents a stunning 650% increase in this time period. Data presented here includes primary, secondary, and early non-primary, non-secondary syphilis cases, which are referred to as total early syphilis, or syphilis cases diagnosed within 1 year of the initial infection. Rates of total early syphilis follow the same trend, having increased 655% between 2003 and 2019, from 2 to 15.1 cases per 100,000. This graph here shows the total early syphilis cases by sex between 2001 to 2019. Steep increases are observed among men, women, and transgender individuals. Cases among men increased 877% since 2003 in Virginia and 115% since 2014 alone. Cases among women are much lower in number, and the rate of increase is not as steep, but there's still an increase of 194% observed between the time period of 2014 to 2019. Cases among transgender individuals increased 3,300% since 2003 and 1,550% since 2014. We think that at least part of this increase, however, may be linked to better data collection of transgender information, as surveillance improved the capacity to capture additional gender information over the years. During the past 20 years, the syphilis epidemic in Virginia changed substantially also. Around 2000 to 2001, women accounted for almost half, or 42%, of the total early syphilis cases diagnosed in Virginia. That changed though. So in 2019, though the count of cases was comparable or even a little higher than the year 2000, cases among women accounted for only 11% of the total number of diagnoses in Virginia. This indicates that the epidemic shifted from a predominantly heterosexual transmission mode in the early 2000s to a majority of the transmission occurring among men, especially men who have sex with men in the more recent years. Looking at rates of syphilis by race and ethnicity helps frame the conversation about health disparities. Rates of syphilis were significantly higher among non-white populations in 2012, 4.7 times higher among Black non-Hispanic individuals, and 1.5 times higher among individuals of Hispanic ethnicity. The story here is that disparities have increased substantially in the past 8 years to rates 7.4 times as high as among Black non-Hispanic individuals and 2.5 times higher among Hispanics. In comparison, the rate for white individuals remained relatively low. The rate of total early syphilis diagnoses increased 55% for white individuals, 149% for Black non-Hispanic individuals, and 253% for Hispanics from 2014 to 2019. A breakdown of total early syphilis diagnoses by race for the latest year in 2019, for which the complete data is available, shows that while Black non-Hispanic individuals only make up 20% of the Virginia population, they accounted for a disproportionate 59% of all early syphilis cases in the state. Sorry, this is the pie chart that shows the breakdown that I'm talking about. Total early syphilis rates by age show the same increasing trends as the national data. Rates increased across the board for all age groups in the past 10 years, but the highest increases were observed in the 20 to 29 and 30 to 39 age groups, with a 129% increase and 253% increase respectively since 2010. While rates among older adults were much lower than the younger age groups, the third highest percent increase by age group was among adults 50 or older, with a 147% increase in total early syphilis diagnoses since 2010. So increases across the board in all age groups in the recent years. This graph shows the 2019 early syphilis diagnoses in Virginia broken down by gender, gender of sex partners, and HIV status. As you can see, the highest case counts are among men who have sex with men only, followed by men who have sex with women only, and men who have sex with both men and women. There are high rates of co-infection across the board among persons diagnosed with syphilis, which makes it imperative that anyone diagnosed with syphilis is also tested for HIV. It's very important. Rates of HIV co-infection are especially high among gay and bisexual men, as well as transgender persons. In 2019, more than half of persons diagnosed with syphilis among these groups were also HIV positive. This graph shows early syphilis diagnoses in Virginia in 2019, broken down by sex and sex of sex partners. Like I said, the vast majority of cases were diagnosed among men, especially men who have sex with men, and men who have sex with men and women, 55% and 11% respectively. 13% of cases were diagnosed among men who have sex with women, and 11% of the cases were diagnosed among women. So this data mirrors the national data well in Virginia. The lower proportion of cases diagnosed among women in 2019 doesn't tell the whole story. Since the number of diagnoses of syphilis among women has been on the rise overall, a smaller percent of the overall number of diagnoses is still a higher number than it was in 2003. Early syphilis case counts increased substantially in Virginia from 2009 to 2020, followed closely by a stunning 450% increase in congenital syphilis diagnoses from 2014 to 2019. Increases in syphilis cases among women of reproductive age are driving this increase in congenital syphilis cases, which mirrors the national trends. 2020 data is incomplete, but as you can see, the number of cases in 2020 has almost reached the total for 2019, with 3.5 more months left in the current surveillance period at the time that the data is reported. Oops. Sorry, I can tell you now that in 2020, we have surpassed the 2019 number of reported cases. We are up to potentially 15 congenital syphilis cases, still refining and making sure that the quality assurance step happens, but we're probably up to 15 cases in Virginia for 2020, which is high, way higher than we'd like to see it. So let's dive deeper into these numbers to show more clearly what a dramatic increase in congenital syphilis we have witnessed in the past 5 years alone. So between 2016 to 2020, early syphilis diagnoses among women doubled when compared to the period between 2011 to 2015, while congenital syphilis cases increased 6 times, from 8 diagnoses to 51 diagnoses in the past 5 years. What's even more concerning is that there were no stillbirths due to syphilis between 2011 to 2015. However, between 2016 to 2020, there sadly were 5 stillbirths that were reported. Any child dying at birth is a tragedy. A syphilitic stillbirth is even more so because it is completely preventable. By testing pregnant women during pregnancy, including in the 3rd trimester, and treating women appropriately as early as possible, but at least 30 days or more before their expected due date, all of these congenital syphilis cases could have been avoided. Of course, there are multiple barriers to testing and treatment for women who have a syphilis infection. A majority of cases diagnosed in the past 5 years occurred because of no prenatal care or late prenatal care due to a variety of factors, some of which included lack of health insurance, homelessness, substance abuse, and mental health issues, and many other reasons. These trends are indicative of a larger, multifaceted issue that cannot be solved by public health alone. However, early identification of cases and appropriate treatment are very effective public health tools that are proven to lower the rates of mother-to-child transmission. I can tell you that in this past year, during the pandemic, the challenges have only increased for public health in providing care for pregnant women with syphilis. So finally, let's go over the trends in total early syphilis diagnoses in Virginia by public health region. The regions with the highest burden of early syphilis diagnoses are the eastern, central, and northern regions. However, increases were seen all over the state. From 2014 to 2019, the number of cases in the eastern region increased 122%, 159% in central, 186% in northern, and 136% in northwest health regions. So across the board, we've seen increases in every region. Going to the county level, this map shows rates of syphilis in Virginia by county in 2019. Rates were highest in the central, eastern, and northern region counties. However, there are a handful of counties in the other regions that also show higher rates. The top 10 county level rates in Virginia, where case counts were more than 12, are all urban areas: Richmond City, Petersburg, Portsmouth, Alexandria, Newport News, Norfolk, Hampton, Arlington, and Henrico. The case rate was highest in Richmond City at 69.2 cases per 100,000 population in 2019. So in summary, Virginia's early syphilis cases were lowest in 2003, but have increased almost every year since. This increase was largely attributable to an increase among men, and in particular among men who have sex with men. Since 2014, cases diagnosed among women almost tripled. This increase in cases among women resulted in a large increase in reported congenital syphilis cases between 2014 to 2019. Unofficial 2020 data that still has to be finalized points to an even larger increase in cases as the coronavirus pandemic has limited testing and clinical care availability. Men who have sex with men accounted for the majority of the reported primary and secondary syphilis cases in 2019. HIV co-infection rates are very high among persons diagnosed with syphilis. The highest rates of primary and secondary syphilis in 2019 were observed among men aged 20 to 34 years in the Eastern, Central, and Northern health regions, and among Black men. So here I wanted to go over the notion of partner services, explain what it is, and how healthcare providers can partner with public health to help early intervention and speed up case investigation activities, which are known to interrupt disease transmission in the community. You may have heard the term DIS, or Disease Intervention Specialists. So who are they? DIS are non-licensed public health professionals who have extensive expertise in case analysis, as well as patient education and counseling, linkage to care, provider and community engagement, and contact tracing and partner services. DIS have been working in STD prevention for decades, but they have also aided tuberculosis outbreak response. They play a vital role in the HIV exposure notification and have also been involved in emergency response activities. This wide array of skills, combined with their passion and dedication employed in the service of their communities, are matched by few others in the field. So, what are partner services in contact tracing? Partner services are offered to people with STDs, to their partners, and to other people who are at an increased risk for infection in an effort to prevent transmission and reduce complications. The historical focus was to identify and locate the sexual contacts of infected people and other people at risk for behavioral and other factors, which is contact tracing, and then refer them for care and treatment as appropriate. The partner is told that they may have been exposed to an STD and that they should be tested and treated. This notification is anonymous or confidential, which means that a sexual partner is not told who referred them. This is a core public health duty carried out by health departments through the DS workforce. The basic partner services process, which is interviewing people with STDs and others potentially involved in transmission, identifying people still at risk, whether through direct exposure or indirect involvement, and bringing the latter to diagnosis and treatment, has evolved to include a broad view of the clinical and epidemiologic activities needed to help people with STDs. However, the partner services and contact tracing approach and skill set extends beyond STD prevention. DS are a public health resource uniquely poised to strengthen the nation's emergency preparedness and response capabilities for emerging public health issues. DS have contributed to multiple outbreak investigations in the US and abroad, including anthrax, TB, HIV, flu, measles, foodborne illnesses, Zika, and even Ebola, and have provided emergency response support after natural disasters, for example, Hurricanes Hugo, Katrina, and Michael. As the healthcare landscape evolves, well-trained DIS are needed even more as patient navigators and network builders to ensure appropriate follow-up of patients. So why do STD contact tracing? There are multiple reasons, all good and with a large public health impact. Health departments can make sure the patient and partners get the appropriate tests and treatments appropriate to their STI. Treating partners can prevent reinfection of patients diagnosed with an STI and further interrupt disease transmission and prevent complications. And contact tracing can decrease the overall number of STIs in the community and therefore improve the health of the community at large. So how does this process work? An individual will test positive for an STI, including HIV. Then the test result that's positive is reported to the health department by both the healthcare provider who sees the patient, as well as the laboratory which performs the test, according to the Commonwealth of Virginia disease reporting regulations. The patient receives a follow-up call from a health department DIS, who will attempt to talk to the patient and offer partner services, including anonymous partner notification. The patient may either choose to notify their partners themselves, which is called patient-initiated partner services, or they may ask the DIS to notify their partners, which starts the contact tracing process. If the patient chooses to notify the partners themselves, they may bring medication to partners under certain circumstances, which is permissible for chlamydia and gonorrhea in Virginia under expedited partner therapy legislation. The patient also tells their partners that they need to be tested and treated. If the patient then decides to not notify their partners after all, they may reach back out to the DIS to ask for anonymous partner services. The DIS notifying partners does so anonymously, not disclosing any identifying information about the person who named the partners. They may notify the partner via email or text, and procedures for this type of notification are currently in development in Virginia. They may attempt a phone notification or a visit to the partner's home for in-person notification if the partner is not able to be located using other methods. The DIS employ their skills to get the partner into the health department clinic in their area for testing and treatment. Then the cycle is repeated if the partner tests positive and becomes an index case themselves. This process, though, may break down if the patient decides to not notify their partners after stating that they would do so, or also if once notified, the partner does not go to the clinic for testing and treatment. DIS do attempt to prevent that from happening by emphasizing the possibility for reinfection if partners do not get treated. The role of the healthcare provider in this process is important. In recent years, it has become more frequent for patients to refuse partner services as trust in public health is diminishing. The diagnosing provider may be able to help by mentioning that a public health worker will contact the patient to offer partner services and explain to the patient why it is important to take that call. It is also important to be aware that according to the CDC treatment guidelines, partners referred for treatment may need to be treated even after may need to be treated even if they test negative for syphilis if their exposure date was within the past 90 days of the negative test, as there may still be in the incubation period for syphilis. So I'd like to end here by providing a brief list of resources for providers, which is by no means comprehensive, including the 2015 STD treatment guidelines as they currently stand, the link to the VDH website for our STD Prevention and Surveillance Work Unit, and also the link for reporting, for case reporting in Virginia on our DDP website. Just to plug, the 2015 STD treatment guidelines will be soon updated. There's already an updated gonorrhea treatment guidelines that was released as an MMWR in December by the CDC. And we're expecting 2021 updates to the treatment guidelines as a whole updated document with many changes coming probably in early spring 2021. So I'd like to stop here and see if there are any questions. Thank you very much, and please feel free to reach out to me with additional questions if you think of any after this presentation.
Thank you so much. And if you have a question, please feel free to put it in the Q&A box. While we're waiting for people to put questions in, I have one that I would like to ask, which is just if you could briefly talk about what impacts the COVID pandemic has had on the surveillance process and how you think it will affect the data from 2020. Just to put you on the spot.
Sure, no problem. So for syphilis specifically, we've experienced a drop in testing across the board, especially in the early months of the pandemic, as the clinical services, were not as available to patients. Appointment times were not available to be obtained, especially starting from March to May or June. So, with a drop in testing, obviously came a drop in diagnosing syphilis. We've also seen the same trends for chlamydia and gonorrhea, but syphilis, especially since it requires a blood sample to be diagnosed, that requires an in-person type of interaction with the provider, and we've seen those testing numbers drop. The situation has improved, but we're still now, with the emergence of the need for health departments and providers statewide to focus on administering the vaccine for COVID-19. We're anticipating even more shortages in clinical appointment times and that are available for patients to get a syphilis test and an HIV test, or really an STI test. So we're working on alternative resources that might be available for patients to get those types of services. The data for 2020 preliminarily has shown some decreases in syphilis compared to 2019, but those data aren't finalized yet, and I do think that trend may not hold when we finalize our 2020 data.
Okay.
Did that answer your question?
Yes. And I see one question here in the Q&A, which is, how much does testing rates affect data with regard to populations impacted? For example, if testing rates have decreased overall, is it possible that patients in all populations are not being tested at the same rate?
Yes, thank you for that question. Absolutely. I do think that it is very possible that patients, are not being tested at the same rate. We already have disparities in terms of STI diagnoses among different population groups. And I do think that access to testing may have been disproportionately impacting our highest risk groups populations. We have, with access to testing, we do have a concern about, even the patient's ability to access transportation services and their ability to get to an appointment in normal times, even before COVID. So I do think that we probably need to look at the data more in depth, the best we can, and try to assess these types of disparities that may have emerged from an added strain on the patient through the through COVID-19. We are concerned that the disparities in underdiagnosing of syphilis may impact our most vulnerable population even more so now. But I don't have good data for 2020 right now to share with the group. Hope that answered the question.
And then there was a question over in the chat, which is, were there any congenital syphilis cases in 2011? And if not, is there a reason why not?
Let me see. I think I need to go back to the slide that you're talking about. Just give me one brief second here. So congenital syphilis reported cases by year of birth and diagnoses of early syphilis among women. Let me find that slide really quickly. So in 2011, let me try and share the screen again. Apologies. Can you see my slide?
Yes.
Okay. So it doesn't look, according to this slide, that in 2011 we had any congenital syphilis cases diagnosed in Virginia, and that's by year of diagnosis. So, you know, that actually is not something that was uncommon. You know, prior to 2009, we also had several years with zero cases diagnosed of congenital syphilis. And I don't have the data with me at this point, but I can go back and check for you some more and follow up. It was, we did have years with zero diagnoses because we had very few cases among women, and we managed them in time, to treat them in time. So 2011 was a good year, but as you can see from 2011 after, the situation has kind of deteriorated, and it's, you know, like I said, primarily due to lack of prenatal care among women at high risk, and also the late screening, or, you know, not screening until delivery during pregnancy. Let me go back to the question really quickly, as I'm trying to navigate these screens here. Yeah, so I hope that answered your question.
And then let me go back over to the chat because I thought I saw one other question over there. Are there any initiatives to encourage primary care providers to routinely screen populations at risk?
Yes, so we're continuously trying to share information with providers through different channels. We've done, prior to COVID-19, we have done a statewide mailing of materials for providers, including printouts of a CDC guide adapted to fit our mailing needs, I guess, with a summary of syphilis and how it looks like, and symptoms and what to expect, as well as the recommendations for screening for STIs, including syphilis, from CDC, with an emphasis on the recent trends that we're seeing among syphilis diagnoses, that we're seeing for syphilis diagnoses among women, and an emphasis on screening during pregnancy and how important it is. That was prior to the COVID-19 pandemic. We've been somewhat rerouted to assist. A lot of the STI program has been helping, or was helping initially through the first half of 2020, kind of support the COVID-19 response in Virginia. So now that we're somewhat back to STIs, for the most part, I think we're going to refocus our efforts this year for more communication, especially after the 2021 STD guidelines, treatment guidelines are released from CDC. We're going to do another campaign, not sure if mailing yet, or another kind of reach out to providers to emphasize the importance of screening during pregnancy, and especially screening repeatedly during pregnancy, during the third trimester and at delivery for women who are at high risk. I do anticipate that the 2021 updates from CDC will include a better definition of who are these women at risk that providers need to screen for repeatedly in the third trimester and at delivery. So that's going to be very important to communicate to providers, and I look forward to making sure that we do that in 2021.
Okay, and here is the $64 billion question for you. I can't wait to see how you answer this. Why are we seeing such drastic increases with syphilis across the nation and Virginia?
That is a really good question. I think, you know, we've been trying to answer that for years. I don't think there's one good answer necessarily. I do think that we do, you know, public health, we in public health need to partner with providers and our community partners and get the message out on the importance of screening and treatment for STIs, and normalize the conversation that patients need to be having with their healthcare providers, their primary care providers, not necessarily their STI clinic providers, but just to be able to take a sexual health history and have that be a normal part of the patient's experience and part of their normal care is what needs to happen more to help stem the rise in syphilis and other STIs that we're seeing nationwide and in Virginia. I think that's really important. There's a lot of stigma associated with an STI diagnosis and with an HIV diagnosis as well, and we would really like to work towards eliminating that and normalizing STI screening and making it part of normal patient care. The more we talk about it and the more we include it in your primary care, I guess, normal course of an encounter, the better we'll be in the long run. And obviously the more we'll test and treat early, the better outcomes we'll have in the long term, and hopefully these diagnoses will start to decrease. With the COVID-19 pandemic, the trends that we're expecting to see for 2020 are, probably kind of skewed. There are increases in gonorrhea that are concerning, even with decreases in testing availability and encounter availability in Virginia, as well as nationwide, as I've heard. So it's going to be really important to continue our work that we do in public health to communicate the importance of testing and treatment and the conversation with both partners and providers surrounding this topic. So I know that doesn't fully answer your question. I do think that the increasing testing that will help resolve this, or at least reverse these trends. Do you see any other questions, Barbara?
I do. I'm just checking, but I don't see any further questions. A couple of participants have information for other participants, so I'm trying to get them to get in the chat for all panelists. But all right, so let me just mention, where did it go? Okay, so there was a comment that in Maryland, much of our female and congenital syphilis is driven by the substance use epidemic, mostly injection drug use, not as much meth use. The women of reproductive age with syphilis, including pregnant women with syphilis, are reporting transactional, commercial sex work and injection drug use. So that was one comment. And then there is a program in Fredericksburg that offers free HIV and syphilis testing. So that is FAHAS, Fredericksburg HIV and AIDS Support Services. So if you're in the Fredericksburg area, they offer free HIV testing and syphilis. And so please look them up because that's wonderful. Okay, so I think that's all just making sure to look, I think that's all the questions. And so moving right along, I'm gonna move us into our next presentation, which is Anne Rompalo, who is a professor of medicine at Johns Hopkins. And she's gonna be going over an entire syphilis overview. So looking forward to this next presentation, and take it away, Anne.
Okay, I'm gonna try. Hold on. Oh God. Just a minute. Let me get my slides up. Let me share screen. Oof. Okay. Now, can you all see this?
Yes.
Yay, okay, here we go. Good morning, everyone, and thank you for joining us in this half-day presentation. I'm going to talk about the basics of syphilis, and Dr. Ganem is going to talk about some challenging cases later on, which I think will be very interesting. But let's talk about what you can't miss with syphilis. Okay, the clinical picture. All right, this is a very complicated slide, but it tries to give you the idea that syphilis is a complicated disease. It marches through stages, but sometimes it skips stages. And remember that early neurosyphilis can happen with primary or secondary disease. So we used to think neurosyphilis was, the end stage, tertiary, but it's not. It can happen very early on. So let's go here, the natural history of untreated syphilis. All right, so what happens, we think, is that in an infamous, let's say, Friday night, secretions are exchanged between partners without a condom. And at the site of inoculation, or where you have sex, so it could be oral, could be penile, could be vaginal, could be rectal, that's where the treponemes from someone who's infected is introduced, let's say, to the other person. So infection. The incubation period is 9 to 90 days, which gives the DIS, which you heard all about. We love the DIS. It gives them time, hopefully, to elicit all the partners and get them treated. But 9 to 90 days and a primary stage ensues. The primary stage can be manifested by an ulcer, as shown here, at the site of inoculation. And it's usually, 6 weeks to maybe 2 months, maybe even faster. So when I talk about how long the stages are, it's very iffy. You can go into secondary. Does everyone go into secondary? No, they don't. But the secondary stage is the spirochetemic phase, where the spirochetes are bloodborne and they go throughout the body. So you can have a rash that's appeared here that can look very dramatic, or it can be spotty, and we'll go into this. Without any therapy, natural history, without any therapy, your immune system gets on top of this, and the secondary manifestations go away, but you're still infected, and you go into latency. And a lot of people are in latency forever, and they don't have any problems. They live with the spirochete. Spirochete lives with them, and when they die, everything dies together. But there are some people that go on to tertiary disease, and tertiary disease is end organ destruction. So what that means is that your body is trying to get rid of almost like the footprint of the spirochete, because when we look at, here's an example of a gumma on the hand, but when we look really carefully with biopsies for these spirochetes, we can't see them there, but your body thinks that they've been there, and this is the result. So you can get gummas, you can get cardiovascular or tabes dorsalis or paresis, which is the psychiatric manifestations of tertiary syphilis. And remember, you can get congenital CSF involvement at any stage, okay? So let's talk about the symptoms. The symptoms of syphilis are any and all. Remember, Osler said it was a great imitator. It is. And here's another ringer. You can have absolutely no symptoms and still be infected. So the major routes of transmission are through sex and in utero from the infected pregnant woman to her fetus, which is vertical transmission. The risk of infection after one exposure is maybe around 40%. It depends on the stage. You're more contagious during primary and secondary stage of syphilis. And some authors think that in secondary syphilis, you can be 80% efficient transmitter, or, around there. So it's an interesting concept of transmission, but primary and secondary stages are the most transmissible. and also the most transmissible to the pregnant woman to the fetus, but a pregnant woman can transmit spirochetes at any stage. So the fetus can get infected at any stage of syphilis. All right, so what happens? So at that moment of sex, when one person is infected and shedding spirochetes and the other one isn't, the spirochetes enter via the skin or the mucous membrane. Now they're slow and persistent. So it's not like staph where they turn over. Staphylococcal aureus turns over maybe every 20, 30 minutes, reproduces itself. Syphilis is persistent and it turns over every 30 to 33 hours. That also, by the way, is why we use long-acting penicillin to kill it when it's turning over. So it has to be long-acting in the blood, high levels, efficient levels for a long time. Now, one of the theories is smaller the inoculum or the smaller the number of spirochetes, the longer the incubation period. This is based on mice models, but okay. Now, dissemination, meaning it goes from the site where you were infected into the lymphocytes, into the blood. It happens immediately. Before clinical signs or symptoms, these little spirochetes can travel through that lymphatic system, through the lymph nodes, through the body, via the blood. And that's why sometimes you can get neurosyphilis really early. Okay. Some spirochetes lodge where the site of inoculation. They turn over, they sensitize lymphocytes, they activate macrophages. And you can see if that Prince or Princess Charming also had HIV, that, those macrophages and CD4 cells are sort of sitting ducks for HIV too. The primary lesion, as I said, which you saw, results at the site of the inoculation, and in maybe 9 to 90 days, the incubation period, but 3 to 6 weeks after the initial infection. The chancre, if you don't treat it, it will heal by itself. Your immune system is very, very interesting and very efficient. Usually it heals without a scar, and it heals in, again, 3 to 8 weeks. Sometimes you can have secondary syphilis at the same time you're healing the primary. That happens more in HIV who are not on antiretroviral therapy. Then you don't have to, but you can march in to secondary syphilis. And actually, this is a slide that goes through what happens on a granular level, where the little spirochetes traverse tight junctions between cells and they get into the perivascular space and off they go. Now, here is what can happen. This is the clinical spectrum of secondary syphilis. And just take a look at this. It's every single organ. Remember, the spirochetes are in the blood, right? So it's spirochetemic, like viremic, spirochetemic. And it can go anywhere: skin, eye, mucosal surfaces, lymph glands. Look at the eye. It's like every section of the eye can be involved in secondary syphilis. I'll mention ocular syphilis a little later on. The nervous system, look, meningitis, asymptomatic, actually. The spirochetes are there, but you don't have any signs or symptoms, but they're still there. You can have like a meningeal vascular stroke-like pattern, spinal cord infarction, etc. It can even get in the lungs. We have seen patients with secondary syphilis who have pneumonitis or nodules or pleural effusions. Musculoskeletal, like spirochetemic, you have arthralgias, sometimes arthritis, sometimes bursitis, and it can get into the kidney with glomerular nephritis, etc., and even into the digestive tract. And we have seen patients with hepatosplenomegaly and hepatitis with syphilis that biopsies show the little spirochetes in there. So when I say secondary, it's usually generalized all over. Now, even with that, if you have a mild secondary syphilis, you may not want to go. You may think it's a different viral infection, and the rashes are related to that. Regardless, if you don't get treated, inevitably the host, meaning you who are infected, will get on top of that, and the lesions will resolve. and you go into latency. Now, we talked about this, 60 to 85% remain asymptomatic. They're in latency for life. And this is when people come in that have a positive serologic test for syphilis, and they can't remember when they were infected, and they're in latency. And you and the disease intervention specialist sometimes work that out, but this is latency. Now, a lot of people stay there, they're stuck there, they don't go any further, but the problem is you have the possibility of going on to tertiary disease, and that's why we treat latency. Get rid of it. Boom, done. Now, immunity, if you're in latency and never get treated, theoretically, you're supposed to be immune to reinfection, and this was based on actually early turn of the 19th century Sing Sing studies, where individuals who were already infected with syphilis they tried to, in the prison, okay, I know this is wrong, but I'm just telling you what the research was. They tried it wouldn't take. So that's what that's based on. But, you know, you're supposed to be immune if you've never got it treated. But the point is, if you've gotten treatment, you can get it again. Okay, now, there we go. Okay, now, but what symptoms should trigger suspicion of this disease? What can you not miss? Okay, primary syphilis and ulcer. Okay, as we said, chancre, 2 to 3 weeks. And you'll see my weeks are vacillating because it depends on the study. But you have an idea that the range is, this says 3, but 9 to 90 days. Keep that in the back of your mind. So the inoculation happens 9 to 90 days at the site of the inoculation or sex. That's where you can get the lesion. There are some lesions here. Typically here, I don't know if you can see my little pointer, but this is a gorgeous primary chancre up here in the right-hand corner, meaning that it's a clean base, there's rolled edges, it's painless, it's indurated. And does it always look like this? No, because it's, can look like anything. But don't miss this. Now, people used to think, oh, it's only one solitary chancre. No, that's not true. Here's a woman who has multiple chancres. She has them on her labia minora. She has it around the perianal region here in the introitus. Kissing lesions. Yes, you can get multiple lesions. 25% of people have multiple lesions. Don't get fooled with that. You can have also regional adenopathy because you're trying to get rid of this. And classically, they're rubbery lymph nodes, bilateral, painless, classically. Now look, somebody can have a primary chancre and also be infected with herpes or have a super infection with a staph. It happens, and in that case, it'll be painful. So talk to your patient. What are their risks? What do you think is going on? And act appropriately and send the right serologic test. Don't miss this.
And
yeah,
your microphone is maybe covered up because your audio.
Okay, can you hear me better now?
Yes.
Okay, thanks. Yeah, y'all tell me when I'm screwing up here. Here's a lesion that came into the emergency room. This person came into, came into the emergency room and said it was a bite. Be very suspicious of bites, okay? You can see that there is regional adenopathy and there's swelling, but this was a primary chancre. Oral sex is sex, and you can get syphilis through oral sex. Here's one on the mouth. This is a gorgeous, actually, lesion, well demarcated, clean base. Here's another one. Don't confuse this with herpes, although you can test for herpes if it's there, but make sure you send a serologic test for syphilis. And if you really think this is syphilis, give them bicillin that day and figure it out. Now, here, multiple lesions, more primaries, gorgeous punched out lesion on the penial shaft, and here's one in the mouth. Oral sex is sex, okay? You can transmit this through oral sex. More lesions that are not so typical. Here's one that's buried up here on the left-hand side, buried in the labia minora. You can see it, but it's well demarcated. Here's one in the introitus, and it looks kind of not so clean in this picture, but that was syphilis. And the cervix is a particularly challenging diagnosis. You look at it and you think, maybe this is gonorrhea, could be chlamydia, but look very carefully for lesions. There actually is around it. You can see, I apologize because it's there's a light around the lesion, but there was a demarcated lesion on the cervix. Who is the patient? What are they doing? What are their risks? And act accordingly. Now let's talk about secondary syphilis. Okay, we have the rash, which can be macular, papular, pustular, any of these. Usually there's generalized lymphadenopathy, but maybe not. Malaise, fever, nonspecific constitutional symptoms, mucus patches, which look in the mouth, can be in the vagina, can be down into the esophagus. Any mucosal surface can have patches that are syphilitic lesions. Condyloma lata, not often, but it can happen, like 10 to 20%. But these are not warts. They're not condyloma acuminata. These are lesions that are moist, heaped up, teeming with spirochetes, and they happen not where you have sex, but where there's warm intertriginous areas, and I'll show you pictures of these. Can be usually around the gluteal folds, labia minora majora, but it can be anywhere where it's like underneath the breast, where there's warm intertriginous areas. You can lose hair, alopecia, and that's because the spirochetes love to lodge into the very tiny blood vessels, and they cut off circulation to the hair follicle, and you can lose hair that way. Comes back with therapy. And then as I showed you before, visceral organ involvement and neurologic symptoms. Here's a rash on the back. It's generalized, it's maculopapular, classic rash. And here's some on the bottom on the right, not so classic that it's everywhere, but there are multiple papular lesions, which was syphilis. And here's a gentleman who has palmar plantar rash. If you see this, definitely really think about syphilis, because there's few diseases, infectious diseases, that cause palmar plantar rashes. The rash is usually not itchy. 60 to 85% involve the palms and the soles, but mind you, it doesn't have to. And I'll show you some mucus patches, which are flat patches, coming up. Here's condyloma lata. You can see that this is in the intertriginous area right here. Heaped up, moist, wart-like papules, teeming with spirochetes. If you ever see a positive dark field, you're going to see it with these, if you have a dark field microscope, that is. And again, this is spirochetemia. It's like viremia. You can have a headache. You don't feel so good. There may be a little fever, myalgias. And we talked about the patchy alopecia and liver involvement. Here's a dramatic rash on the right. Not so dramatic. You have to look closely in the middle. And this is a close-up of a macular papular type of presentation. Even actually, no, yeah. The feet. Look at the feet. You can have only lesions on the soles and not on the hands, so beware. Ooh, look at these. These are dramatic mucus patches on the lower lip, and this woman lost her eyebrows here. They come back with therapy. Again, close up of the rash. I'm showing these because don't you miss these. Oh, look at this. These are small lesions that cross the lifelines. And I was told by one of my professors way back when I first got to Hopkins, she was a dermatologist professor, and she said, and syphilis, secondary syphilis, has no respect for lifelines. There are few dermatological conditions that cross the lifelines. So, Sister Sarah, who's reading your prom, can say you can live another long lifetime, but get down to the STD clinic and get treated for this syphilis. Okay, let's see. Here's on the foot. That's a closer, and sometimes it looks like it's flaking off. That can be part of syphilis. Here's mucus patches on the tongue. Not as dramatic as the first picture I saw, but there they are. And here's some condylomata. Okay, so review again, remember, everything. It involved everything. All right, so latent syphilis, nothing's going on clinically. It's only evidenced by a positive serologic test. So we in the United States tend to call early latent syphilis, syphilis that was picked up within the last year. So it's less than 1 year duration. Late latent is usually with greater than a year. And the reason why we do that is because it's disease intervention, partner contacting. Early latent syphilis, in some cases within that year of picking it up, it can vacillate back and forth into secondary. That's rare, but it happens. So we think the spirochetes are very active and you're still transmissible. Although, you know, I said you're more efficient during primary and secondary stages. It can happen during early latent, so we like to get the partners in and treat it efficiently. Late latent, the spirochetes tend not to be as active, and we want to get the regular sex partner or sexual partners in, but we don't have to do a massive partner notification search in late latent. Now, most of us clinicians end up calling people syphilis of unknown duration because you can't figure out when that happened, and the DIS can help you with that sometimes. But syphilis of unknown duration is treated like late latent. After 4 years, and this is based on Oslo studies on syphilis natural history a long time ago, we think after 4 years, the index person who's infected is non-infectious, but resistant to reinfection if they're not treated. Okay, now here's some tertiary syphilis. This gentleman here with the eaten out nose has gummas. And this is called late benign. I don't think it's so benign, but it's benign because there's no active lesion or spirochetes in these lesions when you biopsy it. But remember that the spirochetes, when they're spirochetemic, can go anywhere and they can go to the mucosal surfaces. And where they go in secondary, your body takes care of it. That's where gummas can set up because your immune system says, wait, there was a spirochete here, let's get rid of it. Okay, so it's end organ destruction. And it can happen in the skeletal region, in the spine, in the mucosal region, sometimes in the eye, liver, spleen, viscera, and it takes a while, 4 to 12 years, maybe longer. Thank God we don't see very much of this anymore, if at all. And here's one on the toe, on the bottom here on the right-hand side. That looks, actually it looks like a diabetic foot ulcer, but if you do a biopsy, the architecture of this is classic for gummas. So the pathologist will help you make the diagnosis in this case. It can cause cardiovascular syphilis, and sometimes we see this where, remember I told you the spirochetes like to get into the arteries, the little small arteries. So they get into the arteries that feed your aorta, and they cause inflammation and they cut off the blood supply. And when you have that cut off of blood supply to your aorta, that lining dies and you can have an aortic aneurysm, and it can be ascending up into your heart or descending, but it takes maybe about 15 years. Now we do see this still, and we have to be careful of it. And here's some more tertiary syphilis. Here's a picture up here on the left-hand upper case. You've seen this before. This is one of the hand, was diagnosed by biopsy. Here's one of the eye, and here's an x-ray where you can see a bulging aortic arch, which actually was cardiovascular syphilis. This is clipped out of the New England Journal. You can look at this, but this is using the gadolinium enhanced MRAs, where it shows that there is an aneurysm right here going right into the root of the aorta. They went to surgery, they did fine. This actually was the case from the University of Maryland. So we talked about a lot of clinical manifestations that you can't miss. But when you do see this, what test do I order? Well, now let's talk about this. Serologic diagnosis requires 2 types of tests. Now, classically, we used to do a reactive protein reagent test, which is an RPR, or a venereal disease research laboratory test. These 2 tests are quick, relatively quick, and they're not specific for the treponemes. They pick up inflammation, so they're not specific, but they're fast and they give you a titer. If that came up positive, then we would confirm it with a treponemal test, and you look at all. It's fluorescent treponemal antigen absorption test, treponema pallidum, particular agglutination, the EIAs, these new tests that we put, that are machine generated. Now look, both types of tests are imperfect. They're not nothing. Unfortunately, with syphilis, we don't have something that's 100%. You can get biologic false positive RPRs and VDRLs. We'll talk about that. You can have falsely reactive treponemal tests like the EIA, and that's could be cross reactivity with other serum antibodies, like with Lyme disease. Sometimes it's a spirochete and you can get cross reactivity. And the reactive treponemal test, that's the RPR or the VDRL, cannot tell you if this is active infection or inactive infection that was treated. So we're going to talk about this. So look, I know this is complicated, but this is clipped out of, where is this? New England Journal, I think. Okay, so syphilis screening. So let's say the infamous Friday night where secretions are exchanged and infection occurs. The spirochete is channeling into the body. You're not going to have a serologic reaction. It takes your body a little while before it says, uh-oh, well, let's make some antibodies here. So when you have primary infection, somebody comes in with those lesions, and the screening test, if you're lucky enough to have a reactive protein reagent, an RPR test or a VDRL test on site, it may not be positive. So when you send it off, it may be negative. Who is the patient? Talk to your patient, see what's going on. Okay, what comes up positive? Well, IgM tests always come up positive, and then they're followed by IgG tests, but you can see here that sometimes it can take, this is weeks, sometimes it can take 2 to 4 weeks before you get a positive test. Okay, I think, and then the tests, when you get into secondary syphilis, all the tests are positive. And over time, and this is anti-lipid, so the anti-lipid test is the RPR or the VDRL, if you will. They can go down over time, believe it or not. But the EIA or the TPPA will remain positive if you don't get treated. Well, actually, for life, most times. Now, this is one of the most important slides. If you want to clip a slide out to have, this is it. With primary syphilis, you can miss maybe 20% of infections if you're only relying on the VDRL or the RPR. However, the FTA, TPPA, ELISA, they come up positive and first, okay? So let's say I come in to see you and I have this lesion and you don't have a dark field and you send off the test. It could be, if they do the classical algorithm, which the VDRL or the RPR is done first, then it can be negative. You need to talk to me and see what's going on. The other thing is you can repeat it in like 2 weeks and see what happens. But I would suggest, if you really think I have primary syphilis, to treat me and sort it out later, because it's a matter of treating me and it's a matter of, stopping the transmission occurrence. Now, when you get into secondary, all of these tests, because you're spirochetemic, all of these tests should be positive, with one exception, and that's called the prozone reaction, where the antibody antigens here with VDRLs or RPRs are so overwhelmed that they don't fall down and you don't get a positive test. So you ask the lab to, you say, please just dilute that out, and then you'll get a positive test, if you will. We don't see that very much, but it happens. It happens, so be aware. Use common sense. And in latency, as we get into latency, late latency, you start losing the VDRL or the RPR, but these tests should remain positive, okay? Right, now, so this is classic. This is the classic algorithm. You do a quantitative RPR or a VDRL. If it's positive, you go on to the TPPA or whatever test you're using, the treponemal test. And if that's positive, you have syphilis. Figure out, is it past? Go back. Is it past? Is it present? What's going on? If the TPPA, or I'm going to say the treponemal test is negative, syphilis is unlikely, but you got to figure out who is the patient. And if the VDRL or RPR was negative, then, and there's no evidence of syphilis, you can stop. Now, that's the classic algorithm. Here's the new one, the reverse algorithm. A EIA, which is an enzyme immunoassay or a chemiluminescent immunoassay. These are tests that you can do that are automated. You can run 100 sera through the machine at a time. The other test that I was talking about is one tech has to read each test. One tech, one test. So you can see where this would be money efficient. So let's say I'm running a blood bank. Excuse me. It's worth my while to run 100 sera instead of one-on-one. So let's say I got an EIA, CIA, right? Either one. It's negative. No evidence of syphilis, stop. If it's positive, then I do a quantitative RPR or a VDRL, all right? If that's positive, then you're right back. You have a positive treponemal test, you have a positive non-treponemal test with a titer. Where am I? I have syphilis. Was it treated? Was it not treated? Where am I? Okay. If it's negative, so I have a positive treponemal test, a negative RPR, and what do? I do another treponemal test, a different one, say a TPPA. Okay. EIA positive, RPR negative, TPPA positive, figure it out. Where are you? Well, I could have early syphilis and it's not manifesting in RPR yet, or I could be late latent and I lost my RPR. That's possible. If the second treponemal test is negative, however, so positive, negative, negative, syphilis is unlikely. Okay? Okay. Now, how do I interpret these tests? Your best friend is your local health department and your disease intervention specialist. Know who to call. By law, they keep a record of positive tests. So you can say, oh, I have Anne here. She has a positive RPR at 1 to 8 with a positive EIA. What's the story? They say, oh, we don't have any record of her. You treat me for syphilis and figure out what stage I'm in. Let's say, oh, Anne, yeah, we know her. Her last test was about 6 months ago and it was 1 to 256. Okay, I'm down fourfold. Now we're going to talk about that. Okay, interpretation of syphilis tests. This is another good slide for you guys to keep on hand. Let's say, and it goes over the possibilities, okay? Just going with the titers. We're going to use an RPR as an example of the non-treponemal test and an FTA as the treponemal test, but whatever you use. The RPR is reactive, the FTA is non-reactive. Well, what could that be? False positive RPR, false negative FTA. Who is the patient? Talk to the patient. Both are reactive. Well, that could be a new case and needs treatment. An old case that was adequately treated. Remember I told you about me, that went, 256 down to 1 to 8. It could be an old case that was inadequately treated. You have to figure that out. Old case that was reinfected. Congenital, other treponemal, sometimes both will be reactive. It's congenital syphilis case. Now we have to keep that in mind now because we're seeing more congenital syphilis. If the RPR is non-reactive and the FTA is reactive, figure it out. We said old case, treated or untreated. Health department can help. Primary syphilis or prosome, which we talked about, which is rare. And non-reactive, no syphilis. Or if I'm a contact, I could be incubating and nothing's coming up positive, but I'm incubating syphilis. All contacts, anyone that comes in to see you needs to be treated for syphilis. I am a contact to syphilis. I don't walk out the door without a penicillin shot or doxycycline. So what do you do with these? Well, the RPR and the VDRL are important because they give you a titer And that's what we monitor for a cure, failure, or reinfection or relapse. So according to historical trends and the CDC, a cure is a 4-fold decline, or 2 dilutions, if you will, decrease. So for example, let's say I come in to see you and my titer is 1 to 32 and I have a rash and you treat me and you have me come back in, I don't know, 6 months to a year. My titer's down to 1 to 8. That's 4-fold. It's 1 to 32, down 1 to 16, down 1 to 8 is 4-fold. Okay. Failure is I don't get down there. So I'm still at 1 to 16 or 1 to 32 when I see you, or I'm going up. Reinfection was I got down to 1 to 8, but now everything was fine. I might have even gotten down to 1 to 2 over time, but now it's going up again, and you better figure out, what am I doing? Am I out there getting reinfected again? Okay, and here is a cartoon on how the 2-fold or 2 dilutions are 4-fold or 2 dilutions are achieved. So let's say I have a 1 to 128 and you treat me, you want to see me go down 2, 1 to 64, go down another 2, 1 to 32 within a 6 to 12 months, or maybe honestly around 12 months. And then over time I can go down and down and down. And sometimes people lose their titers, but they maintain that EIA or FTA. Okay, so this is a slide on who do I screen. And it'll depend. I don't want to spend a lot of time on this because this is King County, shows an example of who they screen. But you guys might have a whole different algorithm. Here's the thing. If I'm sexually active, if I'm on PrEP, I need to have every 3-month screening when I come in to get my PrEP medication. If I'm at high risk, I get screened. Just talk to your patients and find out what they're doing. Screening is a good thing. So how do I treat? Well, it's still penicillin G. Long-acting procaine penicillin is the drug of choice. It's the only therapy with documented efficacy for neurosyphilis or syphilis during pregnancy. The treatment is the same as it's always been, 2.4 million units, IM × 1 for primary, secondary, or really early latent syphilis. You don't have to give extra therapy, and that one shot, 2.4 million is good enough. And if you're not pregnant or you don't have a penicillin allergy, a true allergy now, not, I had a rash when I was 3 months old from ampicillin. I mean, find out what I have shortness of breath when I got hives. That's a true allergy, an IgE allergy. If I have that, the alternative is doxycycline. Ceftriaxone is mentioned here, but we don't have a lot of, you have to give a shot every day, and that's hard to do for primary, secondary, early latent. So doxycycline and 2 grams of azithromycin is out. No. So here you go. Benzene penicillin, 2.4 million units IM in a single dose. Allergic doxycycline, 100 milligrams BID for 2 weeks. Pregnant women, nope. Data to support use of alternatives to penicillin are limited, okay, with primary and secondary. The regimen of doxycycline, 100 milligrams orally twice a day for 14 days. Tetracycline has been used for many years. I wouldn't use tetracycline. It's too hard to take. It's 4 times a day. Doxy is the way to go. Okay. Again, limited clinical data along with biologic and pharmacologic evidence suggests that you can give ceftriaxone in 1 to 2 grams IM daily or IV for 10 to 14 days, and it's effective for primary and secondary disease. But I mean, either the person's in the hospital or you're going to have a visiting nurse come out and do this. It's not a bad shot. It's just that it's complicated. So doxycycline twice a day can be just as good. Now, azithromycin has been effective in populations in Africa, but we in the United States and in Europe are, and probably in Africa now, but they're not looking at it. show that actually the treponeme has outsmarted azithromycin, and it has a mutation in it, which it can't be used. There's treatment failures that are documented. So we don't use azithromycin. Now, you treat somebody, how do you follow them up? You follow them up with, and you see Dr. Ganem is all over this. So if you have questions that you want to, ask him when he gives a talk later, I'm going to dump on Khalil. You follow them up closely, the titers, and you want to see the titers decline, but sometimes they decline slower, and it may take up to 12 months before you see that fourfold decline. As long as it's going down, you're all right. There's serologic criteria for treatment failure. Well, failure is recurrence, persistent, or progression of symptoms, or a rising titer, okay? The frequency of serologic follow-up for primary, secondary HIV uninfected patients is every 3 months. That's wrong. I apologize. It should be HIV infected. I have to fix this slide. And, for latent syphilis, where you're given 3 shots of penicillin a week apart, it can take almost 2 years before the titers start to show that fourfold decline. But as long as they're not rising and going down, it seems like it's okay. Now, treatment failure, you have signs or symptoms that recur or persist, and definitely those with at least a fourfold increase in non-treponemal RPR-VDRL tests that persist for greater than 2 weeks, yep, they're most likely either treatment failure or they're reinfected, okay? Now, why do I say 2 weeks? Because you need to be careful that you're using the same lab to read your titers of the RPR-VDRL. Sometimes labs can vacillate twofold in their reads. So it's nice to have the same lab. And if you think, no, this can't be possible, that's why the 2 weeks are, you may want to have the person come in 2 weeks to have a retest. Anyone who has this and who hasn't been evaluated for HIV, anyone who has syphilis actually should be evaluated for HIV and reevaluated if they think like they're reinfected. Now, because treatment failure usually cannot be reliably distinguished from reinfection, you may want to do a spinal tap, but the new treatment guidelines will tell you you may not have to. And I don't have the new treatment guidelines in front of me, but I will say use your common sense. If you have someone who has been reinfected with no neurologic signs or symptoms, then you can, follow them. Anyone at any stage of syphilis who has neurologic signs or symptoms needs a spinal tap. And honestly, that's what you go with. HIV infected patients are basically followed more closely. And latent, we said benzthine penicillin, IM, early latent 1 shot, late latent 3. Syphilis of unknown duration, 2.4 million units once a week for 3 weeks. Now, what if they miss a week? Well, if they miss a week, then yeah, okay, 1 week, more than 10 to 14 days between the doses, you got to start again. All right, now pregnant women need to come in every week. You can't, it's just, we have to make sure that the penicillin levels stay there, because you're not only treating her, you're treating the fetus. So it's strict. They got to come in once a week. All right, follow-up. We talked about this ad nauseum. I'm going to move to the next one, Ingeris-Herxheimer reaction. Now, you can see this. It's a self-limited reaction to anti-treponemal therapy. So that means either to syphilis or it can be to Lyme disease, but you can see this with spirochetes when you treat. And it's seen more commonly in syphilis with early stages, but it can occur at any stage. And you get a fever, malaise, nausea, vomiting. Sometimes the rash seems like it's getting more prominent, and fever and chills it's not an allergic reaction. It's the Jarisch-Herxheimer reaction. Remember to tell you might see an intensification of your rash or a little bit of fever. That's the antibiotic killing the spirochetes. Usually it happens within the 24 hours after treatment and it resolves. It's not an allergic reaction. If the patient is having shortness of breath or hives, that okay, they need to come in. But hopefully after you shoot them up with penicillin, you have them hang around for at least 30 minutes to see if they're going to have an IgE reaction, and that usually happens then. But after that, it's if they get a reaction, it's this. Symptomatic support is the way to go, and they don't have to come into the emergency room unless they feel like they're going to pass out and then they need fluids. But the thing that you worry about is if a pregnant woman is experiencing this, she can actually have early labor and she has to come in. So pregnant women with Jarisch-Herxheimer reactions need to come into labor and delivery or to the ER to be monitored. Okay, I'm going to skip this one. Some experts administer benzene penicillin after neurosyphilis, if they have the completion of neurosyphilis. Do I have neurosyphilis in here? No, I think Khalil's talking about neurosyphilis. Yes. Okay. Some experts administer, you're going to hear this from Khalil, with neurosyphilis, you usually give 10 to 14 days of IV short-acting aqueous procaine penicillin, and you get, it's like every 4 hours. Some experts give a shot at the end of that just for tertiary syphilis, 2.4 million units. Okay, now one mention, and I don't know if Khalil's going to talk about this, but syphilis control. Should we use doxycycline as a way to prevent syphilis with men who are getting PrEP? And there have been some studies that say that giving daily doxycycline will prevent syphilis infection. And there was a study that was done by Bolin and Associates that was published in 2015, where actually there was less chlamydia, gonorrhea, and syphilis in those people. There's only 30 guys though, MSM, who are taking doxycycline 100 milligrams once a day as when compared to placebo. But there's studies ongoing now. Okay, I think I have completed my syphilis talk with Khalil talking about some of the complications, and he will talk about ocular syphilis, neurosyphilis, and some of the challenging cases this afternoon. But let's do some questions. And if you have any questions as time goes on, go to the nnptc.org website and ask questions. We should be able to answer them within 24 to 48 hours. Okay, Barbara.
Okay, so if you have any questions, please feel free to put them in the Q&A box below. Oops. And I'll just let people think of their questions so far.
Everything is clear.
Oh, here's one. What could cause a false positive TPPA? Is there anything that could cause a false positive treponemol test?
Yes, there are. Lyme disease, for example. Sometimes it's, well, TPPA, some of the early studies were done with FTA, and like rheumatological diseases, for example, lupus, sometimes that will cause it. The DIS a long time ago thought that age would cause that, but I wouldn't go with that right now. I just, talk to the patient, find out what's going on, because sometimes you can have that and actually have tertiary syphilis with old age. So you have to, I know I've been saying this, but you have to look at the patient and then consider what these tests are too. because these tests aren't perfect. Wish we had perfect tests.
Okay, and here's another one. What is your opinion of managing a patient with high-risk behaviors and failure of titer to decrease appreciably by 6 months?
Okay, if it's twofold, then I give them 12 months. As long as you don't see the titer going up, I give them at least 12 months. And I think that's going to be in, again, I haven't seen the treatment guidelines, but I think, and you can ask Colville because he wrote them, for syphilis, I think you should wait for 12 months. Now, with the caveat that there is no neurologic signs or symptoms. So you got to ask them, how's your vision? How's your hearing? You seen any floaters? Yeah, and it's subtle stuff. You don't have to come in with a Bell's palsy. I mean, you need to ask them questions. If they have anything neurologically, oh, well, I'm having a weakness in my foot, then you do a spinal tap. But if they're just hanging, let's say my titer was 1 to 32 and I come back to see you in 6 months, it's 1 to 16, give me another 6 months. Or if it's still 1 to 32, then maybe you want to have them come in 3 months and check it. Again, that's not going up. If it's still at 1 to 32 in 12 months, then I think what I would do, again, go over them neurologically with a fine-tooth comb. They have no neurologic signs or symptoms. I think I would retreat with 3 shots and then see where they go. Does that make sense to you?
And then the other thing I would just add is just to say again that DIS are your very best friend, because even if it's high-risk behaviors, hopefully, DIS are getting names of partners and doing partner services and making sure that all of the partners are getting treated as well. Here's another one from the Q&A, which is, can pregnancy cause a false positive treponemal antibody test?
No. I said that too bad. I would not. I never say no. So let's go back on this. So let's say I'm pregnant and I come to see you and I have immigrated from a country that has endemic syphilis. I might have a positive test. That's not Treponema pallidum subspecies pallidum, okay? It's it's Pertenue, okay? And I know I'm throwing out these spirochete names to you, but it's not sexually transmitted Treponema pallidum. However, in that situation, I would treat the pregnant woman. Yes. Would I treat with 3 shots? Probably. And then I would document it in her record so that with pregnancy in the future, she wouldn't have to go through the same thing again. I have had this patient come, this was a long time ago, from Haiti, when we were having positive FTAs that maybe they were syphilis, maybe they weren't syphilis. But we always treat it as if it were syphilis because it's the baby. Now, here's a question. Did I answer your question? I'm going to throw another one out, which is very interesting. Okay, wait. You can tell me, Barbara, whether I need to follow up on that. If I have a pregnant woman, it's not so much with a TPPA, but if I have a pregnant woman that comes in with a positive EIA, remember, an EIA can be positive before incubating syphilis, or it can be with late latent syphilis without a positive RPR or FTA, okay? So EIA positive, RPR will say negative, and then the confirmatory test, TPPA, is negative. So positive EIA, negative RPR, negative TPPA, and I'm pregnant. What do you do? Now, ask Dr. Sheffield this, but if the likelihood that she does not have syphilis, I mean, really, the likelihood is high, then you can consider it a false positive EIA and move on. But it has all of these caveats with the negative tests. Okay. You want to repeat that test in 2 weeks and see what's going on. You want to talk to that patient carefully. You want to find out what's going on with their partner. I mean, because there's so much congenital syphilis going on these days. But by the book, it should be a false positive EIA. Now, there's a lot of OBGYNs that will just treat because they don't feel comfortable with that. But that's the book. Okay.
So it does say they followed up and said for the particular person they were asking about, they had a negative TPPA in the beginning of pregnancy and no RPR done because it was reverse algorithm. And then second trimester TPPA was positive, and referred to the health department, and their testing came back TP, antibody, IA non-reactive, and RPR non-reactive.
Yeah, and in that case, you would say that that was a false positive TPPA. Yeah, I mean that's what it's supposed to be. Yeah, the reverse algorithms can be tricky, but use your common sense. Look at the patient, figure out what's going on, and if you really doubt everything, and they're not allergic to penicillin, then you can treat. I mean, I fall back on that because, if there's a question and they're pregnant, then I treat.
Okay, and then I have a question that is, have you ever seen a case in which persons who are from mainland China that have a reactive syphilis confirmatory, however, they do not meet the traditional criteria for syphilis?
So they have a positive EIA, is that correct?
Yeah, I guess yes.
Have I seen that? No. And it's a great question for the Californians because they have seen this. I think if somebody comes over and they have a positive EIA and a negative RPR, I might treat for late latent syphilis and document it in the chart and be done with it. There's a lot of syphilis in China. Did that answer your question? Okay, there's something in the chat.
And then it says in the chat, hold on. How do we assess patients who deny all risk factors?
All right. Man. So they deny having sex whatsoever, or they deny, having sex with, oh man. Well, if they have signs or symptoms of syphilis, I treat. I mean, that's a no-brainer. If they have a positive RPR or VDRL, again, I mean, if they have positive both, then I treat. Because then you have to talk to the person. All right, you may not think you have any risk factors, right? I have one partner, and actually I've seen this. I have one partner, and it was an MSM, and he had secondary syphilis, and he thought he was mutually monogamous. His partner did not believe oral sex was sex, and in his mind he was mutually monogamous, but he was having oral sex with all these other people, and syphilis ensued because oral sex is sex. And that's why I was saying, be careful with that. So, sometimes it depends on what they want to tell you. Sometimes they really don't have any risk factors, but their partner has risk factors. So again, put it all together, and if you have to treat. And that's why it's another step to have the disease intervention specialists also talk to them, because they are trained in how to get information. And it's not the clinician-patient relationship. So sometimes they feel more at ease talking to the DIS, and you can get more information in that regard. wait, there's a follow-up in that question too. What is the likelihood of maternal syphilis infection provoking adult lifelong TPPA positivity and a low RP? Yeah, you can see that. What's the likelihood of maternal infection? So are you talking about congenital syphilis? Yes, you can see that in congenital syphilis. That's why you have to document that the child was treated. Because sometimes, and this is from old syphilis experts, and I mean, like, when I was training, they were as old as I am now. They would tell me that sometimes with congenital syphilis, you can see a vacillation of titers that go up and down. You have to document it in the chart with the health department that this person was treated, and that way it will resolve them getting 10,000 doses of penicillin, because sometimes their titer vacillates. We have to keep that in mind. Okay, and in the child she carried, oh no, okay, so I answered for the child already. If I'm the pregnant person and I have syphilis, I mean, and you treat me, you're not going to have enough time. And again, Jean's going to talk about this later on today. You're not going to have enough time to watch that titer go down. But over time, you want to see the titer, like, you know, a year. You're only pregnant for 9 months, but within a year, you want to see that titer go down 4-fold. And she can persist with a lifelong positive EIA, FTA, whatever you're using, and a low titer, sure, as long as that titer's not going up. Make sense? Okay. Any other questions, Barb? Okay.
Oh, I guess what she was asking was
Does
if
the baby be positive? Well, you have to figure that out. I mean, if I'm pregnant and I have syphilis, the baby, you're going to hear all about this afternoon. But if I'm pregnant and I have primary, secondary syphilis, I have a good possibility of transmitting that to the baby, right? The baby's going to be tested. Hopefully you can catch me, pregnant woman, with syphilis and treat me appropriately and complete the treatment at least a month before I deliver, so that the baby gets all that penicillin on board and is treated too. The baby, however, will be worked up for syphilis. And if you think they have any sort of syphilis, and there's like 4 different stages of a syphilis in the congenital syphilis, they'll be treated appropriately with penicillin according to their weight, kilograms, whatever. Or they'll be given a shot. Again, it's in the treatment guidelines. It's not easy, it's complicated on what to do with the baby. But the baby can have positive serologic tests through life. And again, I'm going to defer to my, I don't know about the pediatricians that can, you know, it's interesting. We haven't seen a lot and now we're seeing it. So I think within the next, I don't know, 5 to 10 years, we're going to be able to answer that question about the baby more efficiently, because I have not gone over the serologic titer decline over a lifetime with congenital syphilis patients, because we haven't seen very many of them. So yeah, that's a good question. I'll look it up. I'll go to my neonatologist friends too. They should have an answer. But syphilis in babies is a challenge. And if you go to the treatment guidelines, you're going to see step by step what you need to do. More questions?
Okay. Any other questions? Please feel free to put them in the Q&A box. We have a couple more minutes anyway.
They can have 5 minutes additional break. Jean's going to talk next, correct?
Yes, so
yeah, Dr. Sheffield's going to talk next.
I'm going to stop the recording for this half.